So thank you very much. So when we talk about elimination, obviously prevention is the most important, but treatment is one important strategy as well. So these are my disclosures. When we talk about which patient to treat, obviously the most important thing is to ask ourselves, well, what are the goals that we want to accomplish? We know that we need to suppress the virus, but the ultimate goal is really to prevent progression to cirrhosis, liver failure, liver cancer, and death, improve symptoms, quality of life. For the patients, removing the stigma of infection is very important, and certainly we want to decrease infectivity. I'm not going to get into details about what current treatment can do. You all know very well. We have treatment, particularly with the NUCs, they're very potent in suppressing virus replication. And by doing so, we also reduce inflammation, and we now have data to show that we can also reverse fibrosis. We know that with long-term virus suppression, we can reduce progression to cirrhosis, liver failure, and we can decrease the incidence of liver cancer as well. And the current treatment is very safe, but there are limitations. These treatments suppress the virus but do not eradicate the virus. We can't get rid of the cccDNA or the integrated HBV DNA. The rate of S antigen loss is very low, except for patients infected with genotype A. And so for most patients, they require very long duration of treatment. And while the risk of liver cancer is reduced, it's not completely eliminated. And that's the reason why, unlike hepatitis C, where we now say treat everyone that you've diagnosed, with hepatitis B, we struggle with when to start treatment. For the patients who already got cirrhosis, it's actually pretty straightforward. And if you look at the different society guidelines, essentially, you know a patient has got cirrhosis, you put them on treatment. You don't need them to have high virus level or elevated liver enzymes. But majority of the patients that we see do not yet have cirrhosis. And then we struggle with when do we start treatment. The guidelines are actually quite similar, although the cutoffs are different. For e-antigen positive patients, the AASLD guidelines and the TASL guidelines are very similar. We use a cutoff level for HBV DNA of 20,000, and they need to have elevated liver enzymes unless there are other indications for inflammation or fibrosis. The EASL guidelines use a somewhat lower cutoff. For e-antigen negative patients, again, AASLD guidelines and the TASL guidelines are very similar. DNA cutoff of more than 2,000 with elevated liver enzyme in general more than 2 times. Now note, however, the AASLD defined upper limit of normal for ALT is 35 for men and 25 for women. And you know that in diagnostic labs, sometimes the upper limit of normal can be 40, 50, 60. So we actually use a somewhat lower cutoff. But also we indicate that, particularly for e-antigen positive patients, if they remain e-antigen positive when they're 45, 50, even if their liver enzymes are not elevated, we'll be recommending treatment. And if they have family history of liver cancer, we'll be recommending treatment at an earlier stage. So this is essentially what we talk about when we look at patients who don't have cirrhosis. The current recommendation would be we treat the patients with active disease, but we're currently not recommending treatment for the first phase, the immune-tolerant patients and those in the inactive carrier state. So I've been criticized because I've been involved in developing these guidelines for many years, that we don't recommend treating everyone, and so you allow them to die. You're a murderer. Well, is it really that serious? And one of the things that I want to make clear is, when we sort of talk about treatment, not treatment, it's not so much, okay, I'm going to treat this patient and I'm not going to treat the other one. But rather the question is, the patients in front of me in the clinic today, do I start a patient on treatment now? Or do I monitor the patient and start a treatment later on? Well, what I mean by later on when it is indicated. Well, we know that with hepatitis B, people don't remain in a stable state. And over time, the virus level may go up, the liver enzymes may go up. And so when the virus replication becomes more active, disease becomes more active, that's the time to think of starting treatment. Also, over the years, evidence-based guidelines have evolved as we understand the disease better, as the treatment is better. We liberalize the treatment to some extent. And certainly, one day, when curative treatment become available, we'll be liberalizing treatment. So let's come back to talk about the immune tolerant phase patients. A lot of people say, well, we should definitely be treating these patients because by definition, they have very high virus level. And the review study done in Taiwan showed very clearly that high HBV DNA is associated with increased risk of cirrhosis, liver cancer, and liver-related mortality. Other people would say that, well, with every disease, we always advocate for early treatment and not wait for the disease to become more advanced. And if you treat people earlier, before they have more advanced fibrosis, they're going to have better outcome. And maybe you have less integrated DNA. Immunologists would argue with us that you call it immune tolerant, but you have absolutely no data to show that they're tolerant. And in fact, some of the recent studies suggest that these people do mount some immune response to hepatitis B. Maybe it's not so different from patients in the immune active phase. So let's examine some of these data. Well, I don't really need to go through this slide. You know that very well. The review study showed that higher HBV DNA associated with higher chance of liver cancer, cirrhosis, and liver mortality. Data from Professor Liu's group that if patients remain antigen positive for a long time, beyond the age of 40, even if they subsequently seroconvert from antigen positive to antigen negative, there's a higher chance that they go to the E-negative chronic phase, hepatitis B phase, instead of inactive carrier phase. They have a higher chance of cirrhosis as well as liver cancer. So you really want to control the virus much sooner. Again, this is some data from Taiwan that show that if you follow patients who are antigen positive for a long period of time, you see that depending on when they seroconvert, if they seroconvert very early on before the age of 30, versus between 30 to 40 versus above the age of 40, the chance of having bad outcome is higher if it takes longer for them to seroconvert. So these are all evidence that proponents for treating patients in immune tolerant phase put forward. This is also data from a Korean study that said look, if you have immune tolerant patients and you don't treat them, which is the red line, they actually do worse than the patients with immune active disease, and you treat them. But look very carefully, because the mean age of the immune tolerant patient was 38, and the immune active patient was 40, which is very unusual because immune tolerance should embrace a much wider age range. So obviously, if you pick the older immune tolerant patients, their outcome would not be as good. Well, these are what the immunologists show us. They said it, look, you said it, they're immune tolerant. They really are not. Because if you look at the number of hepatitis B epitopes that the T cells can mount an immune response to, they're no different whether they're immune tolerant or immune active. So they seem to have similar immune response. But I would say that, no, I still don't think that we should be treating them now with the drugs that we have. Now, 10 years from now, we have better drugs. My answer may be different. Well, why not? If the treatment is to prevent HBV DNA integration, we know that integration actually occurs very early, even in acute hepatitis B. So the fact that you're treating them 5 years early does not mean that you can't eliminate integration. There are limited studies in which these patients have been biopsied. They have very little inflammation and fibrosis. And if you follow them over time, the first 5-10 years, very few of them would have bad outcome. And Professor Liu and his group actually have shown us, and all of us know that if you watch them for long enough, some of them do undergo spontaneous seroconversion, and they may go into durable remission. But more importantly, it is because the currently available treatment doesn't work very well for these patients. There are exceptions, however. If patients remain in the antigen, in the immune tolerant phase, the antigen positive, very high DNA, when they're already 45, 50, that's a very different story. We'll be treating them. If they're currently pregnant, we'll put them on treatment in the 3rd trimester of pregnancy to reduce mother-to-child transmission. And certainly, if they require immunosuppressive therapy, we'll give them prophylactic antiviral to prevent reactivation. So this basically shows spontaneous seroconversion. If you look at people, antigen positive for very young patients, 80–90% of them are antigen positive. But over time, you see that as they get older, the prevalence of e antigen decrease. This is because spontaneous E seroconversion can occur. So unlike hepatitis C, where in chronic infection, the virus seldom goes away, with hepatitis B, people can go into spontaneous E seroconversion. And this is some data from Professor Zhu and Professor Liao, showing that in immune-tolerant patients, and here the mean age of the patients was around 28 at the time of enrollment, the first 10 years of follow-up, very little clinical outcome. Now, sure, if you watch them, don't do anything for the next 40 years, someone is going to die from cirrhosis, liver failure, liver cancer. But we're not saying that you don't do anything for the next 40 years. We're saying that you monitor them, and you might be treating them at a later time. And again, I want to come back to this slide because, yes, if you wait too long, bad things are going to happen. But if you actually intervene sooner, then you're okay. Because the first 20, 30 years, those patients who remain e antigen positive have very low risk of clinical outcome. Now, coming back to immunological studies, this is some data from the Hepatitis B Research Network that's funded by the NIH. Everyone said, well, you show immunological response in the immune-tolerant group, immune-active group, and inactive carriers. And when you look at the T-cell response, there's no statistically significant difference. But statistical significance and clinical significance are different. If you look at the height of the bars, you can see that the immune-tolerant group has a lower bar. The immune response is actually not as good. It's just that we had fewer patients in the immune-tolerant group, 21 patients compared to 50, 60 in these other groups. And we have similar number, these might actually reach statistical significance. So I do think that their response is not quite the same. But as I've mentioned, it's really one of the reasons why we say not liberalize the treatment is because current treatment doesn't work very well. And these are really old data from interferon era, where if you, regardless of the HBV genotype, if you look at patients with minimally elevated liver enzymes versus those with elevated liver enzymes, the chance of a response, and here it means e antigen seroconversion, is much lower than those with elevated liver enzymes. So it doesn't work as well. You put the patients through horrible treatment, and they have a very low chance of response. This is also true with the oral antivirals. This is some data from entecavir, and we're not talking about normal liver enzymes. We're actually talking about mild liver enzyme increase, compared to those with ALT more than 2 times, much lower chance of E seroconversion, DNA suppression, and normalization of ALT. Now, these are retrospective post hoc analysis, but there's a study which is prospective, which purposely enrolled patients in the immune tolerant phase and randomized the patients to either TDF monotherapy or combination of TDF and FTC. And what you see is that after 4 years of continuous treatment, not every patient had suppressed HBV DNA, almost no E seroconversion, no S antigen loss, and when treatment stopped after 4 years, everyone relapsed. So it's not that we don't want to help these patients, but with the currently available treatment, we aren't able to achieve much. So this is more recent from the Hepatitis B Research Network, where we had 2 parallel studies, one in children and one in adults. What we did was we pre-treat the patients with entecavir for 8 weeks, and then we continue, but we add PAC interferon at week 8 and go on until week 48. Then we stop the treatment and we watch these patients. And what do we get? Well, very disappointing, because in the children, 2 out of 60 of them did achieve the primary endpoint of E antigen loss and suppress DNA, but in the adults, no one. And in fact, what happened is this one patient who appeared to have a response at the end of treatment actually became E antigen negative chronic hepatitis with elevated ALT and elevated liver enzymes. What was actually interesting to know is that when the treatment was stopped, these patients, most of them remained E antigen positive, and the DNA shot back up very quickly within weeks. But the reason why I still believe that these are immune-tolerant patients was they don't have ALT flare. The ALT stay flat even though the DNA went from 2 log to 8 log within a few weeks. So the immune response to hepatitis B is different in these patients. So I hope I've convinced you that at the current time, with the treatment that we have available, it is not appropriate to liberalize treatment for immune-tolerant patients, except for those who are perhaps older with evidence of fibrosis. But what about the inactive carriers? And I would say that, yeah, we're not going to treat them if we're pretty sure that they're in the inactive carrier phase. Now, the challenge, of course, is some of these patients, you're not sure whether they're in the inactive carrier phase or whether they have e-antigen-negative chronic hepatitis and they're just going up and down. You happen to catch them when the disease is more quiescent. The reason why we're not treating them is because majority of them have minimal inflammation and fibrosis. And again, over a long period of follow-up, the risk of having clinical outcome is low, and we don't know if suppressing low-level virus is going to bring about clinical benefit. Again, each study, you can interpret the results very differently. So this is some data from the review study that people have used to show why we should be treating inactive carriers. Because they said that, look, the inactive carriers have statistically significantly higher risk of developing liver cancer than people who don't have hepatitis B. Of course, we can see that the two lines are very different. But look very carefully at the y-axis, okay? This is 0.005, which means the 0.5% chance of liver cancer after 13 years. And in fact, this is actually less than 1% after 13 years. So if you don't look at the y-axis, you say that the two lines are very dramatic. So yeah, I mean, some of these patients are going to have bad outcomes. But the risk of bad outcome is actually not dramatically high. The key is really trying to figure out whether they're truly inactive. And this is some nice data from you guys from Taiwan, showing that among the patients who are e-antigen negative with low DNA, if you're able to quantify surface antigen, it can further help you identify the patients who are truly inactive and who would have a better outcome. And therefore, you don't need to rush and put them on treatment. But there are also data to suggest that, well, if you were to put patients on treatment, do we always benefit them? And this is actually interesting data from a Taiwan study, from a Korean study, where they actually took patients with E-negative chronic hepatitis B, and they put them on antiviral therapy and compare the outcome with patients who are inactive carriers. And what they show is that in patients with active disease, even when you suppress the virus, their outcome is actually not as good as patients who are naturally inactive carriers. And we actually wrote an editorial in Gut saying that if your own immune response gets you to the final destination, it is much better than artificially suppressing with antiviral treatment. So again, this sort of backs the question that whether artificially suppressing the virus with antiviral therapy in inactive carriers would benefit the patients at all. I've mentioned that some people argue that when we make the guidelines too strict, we're actually hurting the patient. So this is actually data from Myron Tong from a long while ago when he did a retrospective analysis of his clinic patient, and he said, well, I follow these patients who were not treated, and lo and behold, some of them did develop cancer and some of them died. And when I analyzed how many of them would meet some criteria for starting treatment, majority of them do not meet criteria. And if I had followed your recommendations and didn't treat these patients, that's what happened to those patients. But again, it is extremely important for us to remember that the guidelines only serve as a guidance. And the guidelines do recommend that you individualize treatment decisions based on individual patient and disease characteristics. And when a patient doesn't meet criteria for starting treatment today, we are not recommending that you send a patient away never to see them again. We recommend that you continue to monitor these patients, and when the disease becomes more active later on, you're going to start them on treatment. Some people would argue, what's the downside of liberalizing treatment? Because the treatment is convenient, the treatment is safe. Well, there are issues because they're not 100% safe. I mean, there are very minor side effects, but there's also cost. And there's also issue with adherence because when you put these patients on long-term treatment, you think that the patients are on treatment, but many of them, after a while, decide to stop the treatment on their own. So for all these reasons, I think that the current guidelines are reasonable for today. as we have better treatment and our knowledge evolve, we'll be updating those guidelines. And certainly, when the patient's condition change, we'll also be revising our recommendation for that patient as well. Thank you.